Good morning, everyone. I'm Siobhan Martin, Chair of the PEBB Board, and we are convening our February 21st meeting. I am going to start us off with a roll call. So I know our Vice Chair, Don Mottner, is excused today. Greg Klauser. Greg, are you here yet? Not sure Greg's here yet. Chicky Flowers, are you here yet? I don't think, oh, yes. Hello.
Good morning. I'm here by video and by sound.
Great, thank you. All right, Andy, I feel like I just saw Andy pop on screen.
I'm present.
Great, good morning. Kimberly, I see you here.
Good morning.
Good morning. Kate Nass is excused today. Sean Parkman. Sean, are you here? Oh, yep, there you are.
Hello.
Hello. And Rob Nose is not here this morning. That's my understanding. Correct? Yeah. Rob is in the legislative session and he's excused. And I'm going to ask for Greg once more. I don't think Greg's here yet. He was tentative, so I'm not sure whether he's going to join us. So our first order of business is to approve the January 17th meeting minutes. We do have a quorum. There are 5 of us here, so I will vote. And I would like to know if we have a motion to approve the January 17th minutes.
This is Kimberly.
Kimberly, why don't you make the motion? Go ahead.
Okay, this is Kimberly. I make the motion that we approve the minutes as presented.
Thank you. And Andy, was that you?
That was me. I second the motion.
Great. Thank you, Andy. All right. So I will vote to approve the minutes. Chicky, how do you vote?
Good morning. I vote to approve.
Thank you. All right. Andy was our second. Kimberly put the motion out there. And Sean, how do you vote?
Approve.
All right. Thank you. So the minutes are approved. Thank you, Rose, for keeping track. All right, so our next order of business is the renewal responses, round 1. So this is the first time we're hearing what the renewals are, and I'm going to give it over to Andrew for that presentation. Good morning, Andrew.
Whoops, I'm on mute. Good morning. Thank you, Siobhan. So as you noted, today we're going to be going through the round 1 renewal responses. This meeting is really a preliminary renewal review. This is sort of round 1 of likely 3. With the April board meeting, our opportunity to present sort of best and final and review final decisions, that sort of thing. And so our goals today really with this preliminary review are to get board members oriented on where the preliminary financials are coming in for both your self-insured and insured plans. As well as preliminary considerations around proposed plan changes. And so we're not going to be asking for any board action, at least in this first PowerPoint. We will when we get to Canopy EAP, which would be our next presentation. But for this one, really the goal is more just discussion and understanding. And so we'll start off with a review of the claims experience for your self-insured plans. We will show you a, we'll show you a preliminary composite rate increase. So we can see how we're tracking against that 3.4% composite cost cap. We'll go through the preliminary renewal details. And just general comment, there is a lot of content today. And so for some of these sections, we will be moving sort of quickly. And we did decide to pull a few items simply due to having more content than we have time today. And so when we meet next month, we'll discuss WebMD and Weight Watchers, as well as follow-ups from today's discussion. So Maggie, I think we can jump ahead to slide 3. And I'll go through these again kind of quickly so we can get into the sort of meat of the presentation today. And these first 3 slides will be familiar to you all. They cover the vision and guiding principles, strategic health equity pillars, and long-term goals. And so we're going to have each of these 3 slides in each round of the renewals. This is a good time to sort of revisit them, because they can be used as sort of a litmus test on whether a given strategy still fits, as we're looking to make changes to the plan for 2024. For this health equity strategic pillars, this is a document that is updated once per year. And it sort of reaffirms PEBB's intent to make decisions centered on health equity. We do have a health equity impact analysis in this deck. We have another one in the Canopy deck, which will be presented in an hour or so. And so we'll be talking on this topic a little bit more later on today as well. Meg, if you could jump to the next slide, thank you. So these are the long-term goals that the board members decided on and prioritized when we met in late 2022. Sort of split into 3 different perspectives around design, experience, and execution. There are many of the proposed program and policy changes being that will be contemplated by the board that sort of focus on these goals throughout the presentation. The second from last one will be an important one to keep in mind, ensuring the richness of the benefit while managing costs. And so spoiler alert, the preliminary composite rate increase is coming in a little bit above 3.4%. Again, that's preliminary, and I'm not going to steal any thunder from you, Emery, but we'll get to that here in a few slides as well. Any questions before we move on to the self-insured plan experience and how claims have been running against the accrual rates? Realize I went through that kind of quickly. Okay, not seeing any hands raised. So, Emery, I will pass it over to you on slide 7.
Thank you, Andrew. So the next few slides, we'll just kind of quickly go over the self-insured plans and how they ran for 22. So you can see on this slide for statewide, you can see the month-by-month claims, and that's on the slide, the chart on the I guess axis on the left, and then the percentage, the loss ratio, which is the axis on the right, and then some quick facts there on the right-hand side. So there's about 17,000 employees on average statewide. It ran pretty well. So if you take a look at the loss ratio, it's 91.0%, and that's a little bit higher than where it was for 21, which was 90.6%. But essentially, 100% loss ratio would mean that the claims came in exactly as projected. So since it came in below the 100%, the surplus for the year was $32.6 million. So statewide actually has been running pretty well for the last 2 years. Moving on to the next slide. This shows Providence Choice. There's a few more employees on average in Providence Choice, about 18,000. The loss ratio was 97.8%, which is a little bit higher than where it was for 21, which was 96.6%. So the loss ratio is closer to 100%. So the surplus was a little bit smaller, projected surplus, and that was about $7.3 million. Following slide shows MODA. MODA, taking about 8,400 employees on average. I think it's actually grown a bit in January as well. The loss ratio was 99%. So it's basically about at the 100% loss ratio. The loss ratio for 21 was a bit better at 94.6%. Since the loss ratio is 99%, the projected surplus was only about $1.5 million. So as you can see, for essentially the coordinated care model plans, the loss ratios actually were closer to 100%. They were running a little bit where statewide's been actually running quite well. And that kind of gets reflected in the rates that we're going to show in a few more slides. Any questions on medical before we move on? Okay. Let's move on to dental. So since we're only showing the self-insured, this is the MODA dental. The surplus was about $3.3 million, and that's based on the loss ratio of 93.6% there on the bottom right. So that loss ratio is very similar to where it was for 21. The dental plan costs in general have been running pretty well. I think last year, if I remember correctly, did improve the dental benefits, increasing the ortho benefit. So that kind of gets reflected in the claims or the projected rates for next year. And plus, I think we did drop the rates a little bit on the status quo for the dental. So dental has been running pretty well. The next slide shows vision. And vision also is like dental, the loss ratios have been coming in pretty low. In this case, the loss ratio is under 90%, so 88.1%, $1.4 million surplus, and is very similar to where it was for 21. 21 is a little bit worse, about 90% loss ratio, but VSP came in very low for 22. If there are no more questions, actually, we can move on to the next section, which I think I'm turning back over to Andrew.
Thank you, Emery. These next two slides are sort of a recap of where we landed last year with the renewals. And so on this slide, we're showing negotiated savings for the administrative fees as well as the insured premium. The fully insured premium are those blue rows towards the bottom of the table. And so this table shows where we started in 22, what the preliminary proposed change was for 23 in the second column. And then we've highlighted in magenta that best and final after we negotiated going through the 3 rounds of renewals last year. In total, a little bit more than $4 million in negotiated savings. So that was a great result. And you can see the percent change in that second column from the right based on the actual increase in 2023. And again, these are just administrative fees and insured premium, and so this does not reflect your accrual rates for your self-insured plans for medical, dental, or vision. But nonetheless, a good result. The next slide summarizes, again, this is another sort of retro look. It summarizes the major plan changes that were made for the 2023 plan year. This is largely for your reference and to refresh you on some of the decisions that were made in April and May of last year. There was a net cost reduction of $6.7 million that was largely driven by that first row, the manufacturer coupon program for Providence. There were some other items that added cost as well. There were enhancements made across medical, dental, and vision. And you can sort of see the ups and the downs in that second column from the right. Any questions on this? Doesn't necessarily inform decisions that board members are going to be needing to make for 2024, but good to sort of reorient to what the focus points were last year. Granted, the composite increase was different last year than it is this year, and that's going to be the case every year. But hopefully this is helpful as a sort of reminder in terms of these major changes that were made for 23. Okay. I think at this point, Emery, I'll pass it back over to you for the preliminary rate increase and preliminary composite projection.
All right, thank you, Andrew. So let's move on to, thank you. So this slide shows the admin fee increases that are projected for 24, shown there, and then the preliminary rate increases in the next second from the right column. And then on the far right, we do show total 2024 projected premiums based on the January enrollment, and that's about $1.2 billion in total for PEBB. So as we go down, we show the medical plans for the first 4 rows, and then we show dental and then vision, and then we do include standard down at the very bottom. So going from the top, Providence statewide, we have a preliminary rate increase of about 3.7%. As we take a look at through the medical, you can see that's actually the lowest increase of all of the medical plans preliminarily. Providence Choice is at a 9.2% increase. One thing to keep in mind for the medical, I did increase the trend a little bit, about 3/4 of a point on the medical, as a nod to some of the stories and the information and the recontracting that's been going on across the the different insurance plans and across the state. And so these rate increases do include a little bit higher trend rate, which impacts that preliminary rate increase in this case. For Kaiser, that's fully insured. The preliminary rate increase is 13.5%. That does include it's an early release on the Kaiser premium rates. There's a little bit maybe conservatism in the trend rate that they're using, and hopefully that will come down as we get more experience and as we get closer to the final rate. But right now, preliminarily, it's coming at 13.5%, and that's for both Kaiser HMO and Kaiser deductible. For MODA, their rate increases at 10.2%, so that is higher than statewide and choice. One thing that I did look at, and we'll probably want to discuss this, maybe not in this meeting, but in future meetings. The plans, as you can see, the rate increases for Providence Choice, Kaiser Deductible, and MODA are coming in at about 10% or higher, and statewide's coming in at 3.7%. That unfortunately does essentially mean right now, preliminarily, there are no low-cost plans. The rates for those plans are within 10% of statewide. And so the contributions, that's going to have an impact on the contributions. So we'll need to talk about this, and at least, hopefully with more experience, we'll see what happens. But that is an issue that we'll need to address moving forward. For dental, we show MODA Dental, Dental of Oregon. That rate increases about 2.9%. So that's just a little bit below the 3.4%. Willamette Dental Group and Kaiser Dental are both coming in at 0%. Their rating kind of shows that it should be a little bit of a decrease, but right now their initial preliminary rate increase is just holding the rates flat. And for VSP, we are projecting a 0.6% decrease for VSP. And then standard, there's no rate increase there. Before we move on, I wanted to open up for questions or comments.
I was just going to comment, I appreciate you highlighting that there are no plans that are within 10% of the highest cost plan, and we absolutely are going to have to pay attention to that.
Yeah, it's been like 2 years of kind of similar rate increases where I think the coordinated care plans have been coming in higher than statewide. Last year, there was enough buffer. This year, after 2 years of 5% or 6% differences, deltas between the rate increases, unfortunately, that gap has gone away. Okay. Moving on to the next slide. This shows the composite rate. We have some of the historical, so you can take a look all the way back to 2015. If we take a look at the final 2 lines, so 23, we had about some changes last year to get to the 3.4%. So there was a PEBB admin increase to 0.9%. There were some plan changes, and then it still came in below the 3.4%, and so the board elected to apply a funding assessment of about 1.9%. That 1.9% essentially added a buffer or margin in case there was going to be a higher rate increase, which unfortunately there has been for this year. And so with that 1.9% buffer, the preliminary increases, as you saw in the prior slide, some of the plans are coming in well above the 3.4. But once we blend everything together with dental and vision as well, and that 1.868 funding assessment, the composite rate's coming in at 4.8%. So that is above the 3.4% limitation by about $16.8 million. So that's kind of the number we need to take a look at least. And while we're not, providing any real substantive plan design changes to whittle at that deficit, we will talk about it, and hopefully as we move on, as more experience comes in, maybe the ratings and premiums will come in a little bit lower to help mitigate that impact. Are there any questions, comments? Okay.
Just
Well,
appreciate the overview, Emery, on where we are.
Emery, this is Ollie. I was, for the new board members, I would just say this is, again, round one. And I think that, you know, we have long partnerships with our plans, and we hope that we can, you know, sharpen pencils with each round we go through and get to our target without making any plan changes. So just wanted to say that.
Okay. Well, thanks. Actually moving on, I'm going to turn this over to Sally.
Sorry, excuse me, I had to unmute myself. Good morning, everyone. I'm going to start with this slide, which is just gives a snapshot of all the PEBB programs that we're going to be reviewing in the next slides. So all of your programs and vendor partners. So for medical, dental, vision, life, disability, and then the supplemental programs. So Maggie, next slide. Or next. So this first slide, so Emery reviewed the overall cost projections. This provides a little more of the nitty-gritty of the self-funded plan administrative fees that are being proposed for 2024. Both Providence and Moda are illustrated here. And you'll see that they are exactly the same in terms of the proposed increase of 2.9% across the plans for the medical administration. I will note that for Providence, they are in the medical case and disease management. There's a new program that is embedded in there, the PEBB, which we'll review on a subsequent slide. It's a physical therapy management program. And historically, you saw from the previous slide that Emery reviewed is that the like Providence last year came in with about a 3% increase on the plans. I think it was like 3.2 on statewide and 2.6 on choice, but we ended up at no increase last year. And then Moda was at no increase last year, but this year they're asking for 2.9 on the basic admin, and then on the Moda 360, the variable fees are not going to change. Any questions before we move to the next slide? And I should note these are preliminary, as Andrew emphasized, that they both emphasized. So Providence provided some options for consideration and also responded to some requests from us. So the first one was on the statewide plan. Currently, there's no massage therapy benefit, but there is one on the choice plan. And so they're recommending adding a massage therapy benefit to the statewide plan to provide some benefit parity across the two plans. Proposed plan would mirror the choice benefits. So it was 15% coinsurance and an annual benefit maximum of $1,000. And members would be able to access care through any licensed massage therapist that they wanted to. But if they were to receive care from a therapist that actually participated in Providence's ASH network, they benefit from the contracted discounts and from the elimination of balance billing. The estimate that we have for adding this benefit is $3.4 million. On the choice plan, this is an administrative change that would have limited cost impact, but they're recommending eliminating the referral requirement. Currently, in order to see a specialist under the choice plan, a member has to receive a referral from the medical home. But this has created a bit of an administrative burden both for the medical home and the health plan. It also, maybe it diminishes, the member experience. So the goal is really to create some plan equity and to improve the member experience by removing this barrier to care. And the recommendation is also consistent with kind of the shift in what's happening with these gatekeeper type models, where they're no longer using that formal referral practice any longer. And as I mentioned before, this would have limited cost impact to the plan to eliminate this referral requirement. And then the final consideration is elimination of the anti-obesity medication exclusion. I think, Andrew, did you want to jump in on this one to talk about it?
Yeah, thank you. Sure, I'm happy to. The other comment I would make on the massage therapy before I get into the anti-obesity drugs, today there isn't medical necessity required, and so that might be something else that we might want to consider in round 2 if there's interest, and see what that does to the estimated cost impact, if that benefit were expanded into the statewide plan. So yes, the anti-obesity drugs. This is a topic that's getting a lot of attention right now in the media. I'm seeing NPR articles, New York Times, lots of other sources. In addition, there have been some member emails that have been circulated on this topic. So there are a class of drugs called GLP-1 drugs, which are on the formularies today with your carriers for folks who have type 2 diabetes. And so this change is proposing expanding eligibility to include folks who are using it for anti-obesity purposes as well. We did put an asterisk next to that estimated cost impact, and the reason we did that is because we think that if this strategy is pursued, it probably makes sense to, in year 1, create some utilization management and eligibility criteria that limits who's eligible for these drugs, because they are quite expensive. And so the strategy being that this would be a phased rollout, where in year 1 you're focusing on folks who have, a BMI over, let's call it 40, which is going to limit who's eligible for these drugs. And in year 2, we reevaluate, look at what the results have been in year 1, and potentially start phasing that eligibility requirement down, perhaps to a BMI of 35. And there could be other eligibility criteria as well. I'm just using BMI as an example for what a phased sort of rollout would look like. So we did pull some data on the Providence and MODA GLP-1 utilization today. So maybe we can quickly jump to that, Maggie, on slide 42.
Andrew, before we
And
do
Andrew,
that, yeah,
did you see
Sean
that
had a question.
Oh, sorry. Thank you. Yes.
So just a quick question on the anti-obesity medication. I'm less familiar with the details at this point. So it's your general assessment, or the community's general assessment, that this medication, the benefits of the medication outweigh the risks, as far as, I mean, the whole purpose of containing obesity is because of health outcomes. So the health risk of the medicine is outweighed by the benefits of the reduction in obesity, and that evidence is fairly clear at this point, that there's a clear win related to this drug. Is that correct?
So
This is
great question. Yeah, Sarah. Yeah, please jump in.
yeah. Hi, I'm Sarah Drake. I'm the pharmacist by training, and I've been supporting some of this work. And yes, the GLP-1 drugs, unlike some of the previous drugs for anti-obesity, they are kind of game changers in terms of both the magnitude of the weight loss that can be achieved with the use of these drugs as part of a comprehensive program, and then also that the side effects tend to be relatively mild and short-lived. People that do get the more severe side effects, which tend to be like GI in nature, like diarrhea type stuff, if they stop the drugs, it goes away. So there's really aren't long-term effects. The drugs work, and they work very well. And I think that's why we're seeing anti-obesity treatment talked about in a different way over the last year, because these drugs are now on the market and the outcomes are so good.
Thank you.
And I just wanted to say, I think would be helpful for those of us on the board, I know for me, to just get more information that can be shared with board members around these drugs, just because they are newer and we're hearing about them now.
Yeah. So Siobhan, we did include some slides in the appendix, which looking at, I'm just doing a quick time check. And so we pulled some data specific to the PED population starting on, yep, slide 38. Thanks, Maggie. Sean, did you have another question, or I see your hand still up,
Yeah,
or maybe?
I do.
Yeah, go ahead.
So,
Okay.
yeah, yeah, it would be good to just have some reference. That's great. And if it's already in the appendix, super. This does bring up a general question that we always end up broaching when we come to renewals. So we may as well just kick it off with this one, which is sometimes there are changes that are proposed, but not super clear that it really needs a board approval because it's just sort of like medicine. Like if a doctor prescribes a thing, then like who's stopping you? And so my question for this drug in particular is like, is there a specific rule that we've already made that prevents them from prescribing this that we need to overturn somehow? Or are we just kind of like flagging it for our interests? Or like why does the board need to make a medical decision for patients, I guess? You know what I mean? Like if the drug works, it's great, and the doctor thinks you need it, they're just going to prescribe it at the end. Like it's sort of like needs no further approval. So can you help clarify like what's the special dynamic here, I guess, that requires an extra approval?
Yeah, that's a great point, Sean. And you're right. Historically, like formulary changes are not something that the board sort of weighs in on and approves or denies, right? We think this one is a little bit different because one of the strategies that we'd propose, if you decide to sort of, if the board is in agreement with this strategy, is to ask the carriers to partner with a third party vendor who really provides health coaching, eligibility management, and tapering of the drugs. And so with the intent being that, members who are using these drugs use them for between 12 to 24 months, give or take. And this additional carved out solution would provide the health coaching and sort of lifestyle coaching that would be needed for a member to successfully taper off of this drug. And so it's just, from my perspective, I just think it's a little bit more nuanced than some other formulary changes, which are just sort of course of business. The plans update their formulary twice a year or however often they do it. So I guess that's
Okay.
that's sort of what we're thinking for why. Yeah.
I appreciate that. So last comment, and then I'll be quiet. So it's your assessment that without our direct intervention, our managed care, our coordinating, our managed care plans will not be able to effectively introduce this drug in a responsible way?
Sarah, I wonder if you have a perspective on that and the additional sort of value that a point solution could provide above and beyond sort of the care management piece that the plans would be doing.
Yeah, I mean, I think some of the challenge with these drugs is that even though they have the same active ingredient, there's products that are approved for diabetes, and then there's products that are FDA approved for Wegovy, or FDA approved for obesity. So the manufacturers are actually marketing it to two different disease states. And so the ones that are marketed for diabetes, the managed care partners have appropriately set up authorization criteria so that the members who are getting them, are the members who have type 2 diabetes and have perhaps used other appropriate agents. I think the question on the table is for these products that are FDA approved only for treatment of obesity, and what should be kind of the guideline for who is going to use those. And I think these drugs are a particular challenge just due to some of the media interest in the drugs. That it's been on TikTok and Kim Kardashian and a lot of different people talking about the GLP-1s. And so you definitely want to make sure that you're managing the demand and making sure that the right people have access to the products, and then also the people that want to use it for more cosmetic purposes are not. And to Andrew's point, I think the value of like the point solution is to make sure that the people who are using these drugs have the best chance of getting the best outcomes from them. And that's with a comprehensive program that includes not only just the drug, but also like a lifestyle management intervention so that the members can kind of get this reset in their metabolism and then be able to move forward, hopefully, eventually without the drugs.
Yes, and just to, I think there was a couple of comments in the chat, and for those who don't have access to it, but yes, I mean these drugs are weight loss drugs are explicitly excluded, and so to change that would require board approval. I'm trying to remember the history of it. I believe it would. I could speculate. But I think it's been a while, and we can take a look at it. But it would need to be changed.
And Emery, it might be, going back 20 years or more when the drugs that were approved for weight loss, like the fen-phen, didn't work particularly well, but there was a lot of demand for it and it was dangerous. And so that, that might have been some of the history there.
We do suspect there could be some off-label use of these drugs today. If we could jump to slide 42 and Aggie. It's a little bit difficult to say that with 100% confidence just in looking at the data, but if you look at the increase in GLP-1 drugs, they're increasing significantly, but part of the change for that, Sarah, right, is that there are new clinical guidelines for prescribing these as an earlier intervention for folks with type 2 diabetes. And so there's a little bit of noise in that data, but and we're seeing that for both MODA and Providence, which is on the next slide.
Yeah, and the huge year-over-year change is really driven by an increased number of members utilizing the drugs. So it's not that the drugs are increasing in price, even though they are. It really is more people using them. And like Andrew said, the clinical guidelines have changed so that they're using the GLP-1s earlier in treatment for people who have significant cardiovascular risk on top of their type 2 diabetes. And of course, that tends to be people who have obesity. And so, part of what we're looking at is, are they using it for their diabetes? Are they using it for weight loss? If they could benefit from weight loss and perhaps that helps their diabetes, how can you make sure that they're getting the best treatment for that obesity so that they can kind of effectively treat both conditions well?
And apologies if I missed this. Are all of these drugs designer drugs that will take a while for there to be generics and for the cost to go down, or where are we in that continuum?
Yeah, the GLP-1s, so the newest versions of the GLP-1s, which are a once-a-week injection, those we're probably close to a decade out on generics for those.
Thank you.
Okay, I guess if we want to jump back up to 21, if folks, board members want to look at some of those additional slides in the appendix, there's probably more discussion to be had here. And we're happy to pull additional data and do additional analysis as needed. But I guess in the interest of time, maybe we'll want to jump back up to slide, I guess we're on 22 now. Unless there are any other GLP-1 questions, I think, Sally, let's jump to slide 22.
Okay. So continuing on with Providence, some other considerations. I mentioned before when we looked at the administrative fees that in the medical management fees incorporated into that was the EviCore Physical Therapy Utilization Management Program. This is a program that is not new. It was presented to the board back in 2019 and was approved by the board, but the implementation was delayed because Providence wanted a little more time for provider education and to have a favorable member experience because they were rolling it out to their entire book of business. But they feel like it's ready now. So they feel like it's ready for prime time and want to recommend it again. This is a program that would allow members 12 physical therapy visits up front. And then at that point, there'd be a medical necessity review for additional visits to ensure there's appropriateness of care after that 12th visit. Our understanding is that most conditions have resolved by the 12 visits, so there are very few people who probably go through this prior authorization and be affected by it, but they felt like this is the appropriate point to be reviewing the care that's being received. And really the purpose of this is to ensure the appropriate utilization, address any potential, and in addition to address any potential mental health parity concern by aligning all of the utilization management programs. And this we estimate to be a $1.1 million cost savings to have this program implemented. The next program is one called RX Saving Solutions. This is another layer of support to the member to provide them with some additional pharmacy savings if their drug qualifies. It's essentially a program where they're going to basically scrub the claims data, look for prescriptions that could qualify, and then they'll reach out to the member to offer them the option of taking advantage of it. So it's not required for them to participate, but in the end, they could end up saving money and the plan could save money. And some examples of changes they could make would be like changing from a tablet to a capsule, different drug strains, or maybe a different drug option. If it was determined that it's a different drug option that required a new script, the program would reach out to the physician to request that new script. This is a program that they are going to be rolling out to the rest of their commercial book of business either later this year in 2024. And so they wanted to recommend it. The cost that we show there, the 1.1 million, is the administrative cost, estimated administrative cost. We feel like that would probably be offset by some of the savings that would be gained by implementing this program, but we don't have an estimate of that yet. And then the final item on this list is the elimination of sexual dysfunction medications, or that elimination of that exclusion. It's currently excluded. These are drugs that are relatively low cost. There are generic alternatives available, and there are multiple uses for these drugs. Adding coverage would ensure members who need the medication for medical reasons would have access. There was a member complaint last year about this particular exclusion, and this would have a minimal impact to cost to make this change. Any questions that you have on this page? Or these options? Okay, Maggie, you want to go to the next slide then? So the MODA considerations, there's several that they've offered. The first one is a Copay Plus Max program. This is similar to the program that implemented with the Providence Plan this year. This is one of those coupon programs. So essentially, it's taking advantage of the manufacturer coupon and ensuring that the member gets enrolled. If they are enrolled, that the information is captured, and so the true cost sharing is captured under the program. Because currently, if they have a manufacturer's coupon and they're not paying anything, they're still having the cost under the plan accumulate to the out-of-pocket maximum. So this would ensure that doesn't happen, that their true out-of-pocket expense, whatever that is, would accumulate toward the deductible and out-of-pocket maximum, which would result in increased savings to the plan. And in 2021, there were 204 members who would have benefited from a program like this. The next three programs that MODA is recommending, I think they reviewed in the last board meeting. The first one is language services, which is expanding the interpretive services for members. I see a question there from Sean. Should I stop? Sean?
Sorry, yeah, I didn't mean to interrupt your flow there. When you get a second, can you just flip back to the previous page just for a second? I was taking some notes. But when you're ready. Yeah, that's great. Savings. Okay. Yeah. All right. Thanks. Appreciate it.
Oh, so we're okay now? Okay. Okay, so I'll continue. So the language services, this is providing some expanded interpretive services to members. So currently, if they call in, the interpretive services are available either by phone or in the member materials. They're translated materials, but not in the physician office. So what they're proposing is to add coverage for the services being provided in the physician's office. So those would be billed, so either in person or telephonic remote. These would be billed as a claim. as a cost of the plan. The second one is nutrition support, and there's a couple of programs that they've recommended. They've got their one program that provides, basically it's for members who have type 2 diabetes. It's providing them with two dimensions. There's a medically tailored meal program after they're inpatient. So once they're discharged from the hospital, providing them meals in the home to ensure that they're getting the proper nutrition. And another one is called Food is Medicine, which provides food to the entire family for those who have type 2 diabetes to make sure that they have the adequate support in terms of the food that they're eating. And then the final one is Flex Funds. And this is a program where they will provide support to members trying to connect them with community resources. And if there aren't community resources available, these plan funds would be used to reimburse some expenses just to help to support them. So things like paying for a rent application or mold and pest mitigation or assistance in paying a utility bill. All three of these are TBD because well, all of them are TBD in terms of the cost implication. Also, we want to explore these a little further in terms of the compliance issues that there might be with these in terms of taxation of the benefit. So we're waiting for some additional information on that. Do you have any questions about that? Or Andrew, do you have anything you'd like to add to any of these? And then the anti-obesity medication, I think we've discussed. It's the same conversation, I believe. Right, Andrew, in terms of what we wanted to discuss about that. So.
Yep.
So Sally, I just have a question going back to slide 22. So if Rose, you can go back one.
Okay.
I realized I was confused when we're adding the prescription savings solutions program. Why does that cost 1.1 million to add?
There's an administrative fee. There's an administrative fee associated with that, Siobhan. So.
Okay.
Yeah.
It's conservative. That's likely more like cost neutral, that item. And so what we're doing is we're looking at the projected utilization of this program that Providence has supplied with us to sort of validate that. And so that's really just the administrative cost. There is going to be an offset there. So I think it's likely more like cost neutral.
Okay, thanks. I was just trying to process that. And I just want to make sure, Sean, did you have a question? Any other question?
Yeah, I'm good. Thanks.
Okay, thanks. Thanks, both of you.
Okay, so Maggie, we can move to the next. Okay, administrative changes with MODA. There are a couple administrative changes they're proposing. First is the pharmacy network. Currently, CVS is not a network pharmacy, but they have been processing claims received from them, and they're paying them the contracted rate they would pay to a network pharmacy. Under this change, they are recommending completely eliminating that reimbursement. They have a requirement in their participating pharmacy contracts that precludes reimbursing CVS. And so they're recommending that this particular provision be eliminated. And right now there are no members who are affected by this. The second has to do with out-of-area dependents. Currently, if they live outside the service area, they receive benefits via MODA's travel network. And if there's not a travel network provider nearby, then they can, as long as services are received within 30 miles of their residence, they will pay them in network. The change that will occur is they will actually assign them a network. They've got out-of-area networks. They will actually assign the children residing out of the area to a network, and that will be the network they use to receive benefits. So this is just a minor administrative change to ensure that members are receiving in-network benefits. And we're recommending accepting both of these. And then the final is the new program, which I mentioned just in passing when we looked at the fees. And this is MODA's Behavioral Health 360. And this is a program to provide some additional behavioral health support to members. And so there will be a specific team that is available to guide and assist them in finding providers and finding providers in the network and providers who can provide the kind of care that they need, and some additional decision support tools, and basically providing just a better experience for the member. And there is an administrative cost to this program of $1.76 per employee per month, which wasn't included on the slide with the administrative fees. And that has an estimated claims impact about $550,000 is what we've estimated. Do you have any questions about any of these proposed changes?
Sally, one comment I'd make on the Behavioral Health 360 program is there's an additional admin load, as Sally mentioned, but there's already an existing load for behavioral health utilization management in your ASO fee, a much higher fee of $7 and change. And then it's broader than just behavioral health. It's also sort of general utilization management. But we've got some questions that we're working through MODA with on that piece. The other thing I'll mention is that we did do a health equity review of this program, which you can find in the appendix. You know, generally, we think that the idea of this program is a good one. There are some areas of opportunity, as there's always going to be around, you know, use and tracking of, you know, real D and SOGI data and some other things, monitoring for health inequities. But on the whole, it does seem like it would be an effective program. So those slides start on slide 49. If you want to take a look at those as well. We've just got 15 minutes for this presentation, and so hopefully that sort of quick overview was somewhat helpful, but feel free to look through that content and read through our findings from a health equity perspective as well.
Okay, Maggie, ready for, there we go. So Kaiser Permanente, they have a couple of considerations that they've put forward. First is for home health care. Currently, half of the PEBB plans do not have a visit limit for home health care services. And so they're recommending aligning the plans so that they're adding a 130-day annual visit limit on the traditional and the $100 deductible plans for full and part-time employees. And this 130-day limit is a pretty standard in the industry. That's what you see across most plans. So that's, anyway, and so we recommend accepting it. The second one is the Kaiser Permanente at Home, which I think they've talked about before, which is adding coverage to the plans for care in the member's home as an alternative to acute care in the hospital. And this includes home visits by healthcare professionals, you know, communication devices, medical necessary supplies, and equipment. And we recommend accepting that as well. And then travel and lodging benefits. So this is, we started looking at this really to address the potential need for travel for reproductive health services, but it's a little broader than that in terms of how we have structured this in terms of the options. So we went to both Providence and MODA with two options and asked them whether they could administer it and what they estimated the price impact would be. And so the first option is broader in that it essentially it provides for travel and lodging benefit for any authorized covered services if there's not an in-network provider available within 50 miles of the member's home, and it caps that benefit at $5,000 annually. This benefit's available to the member plus one adult companion. It intended to be in compliance with the IRS regulations in terms of the reimbursement of travel and lodging benefits, which is for lodging is $50 a day. And you can see that MODA provided an estimated premium impact and member impact and cost. Providence thought it would be negligible for that option. Option 2 is a little more nuanced. It has a few more provisions to it. The first is the travel within, there's no provider within 50 miles of the home. The second is when services are received in another state because it's not available in the home state, and so they need to travel for it, or if services are provided by a Center of Excellence, a COE, is recommended. The same $5,000 annual limit, and then you can see the cost impact estimated under the MODA plan, and then Providence's was negligible. And then with Kaiser already provides a travel benefit when it's necessary, medically necessary. It did not include the pregnancy termination or anything for reproductive care, but it can be added. And it's just a general benefit that there's really no initial costs associated. The cost would flow through at renewal if you chose to add it, if the benefit was utilized. So really oh, hi, Sean. Sean's asking a question. I was going to say, though, the purpose of this was really to come up with a couple of options in order to address the reproductive health services and actually provide a more condition agnostic benefit that was in compliance with IRS regulations. Sean? You have a question?
So we're talking specifically about reproductive health services for these two options, is that correct?
It's actually broader than that. We started to explore it for that purpose, but really we were looking a little more broadly to come up with something that's more condition agnostic and to ensure that the plans are in compliance with the IRS regulations and making sure mental health parity in terms of that the benefits available for all services under the plan if you can't receive them, but with some qualifiers there, as you can see. So, but that was the impetus, to be honest, that was the impetus though, was reproductive health and first starting the conversation.
So we don't have a COE program currently, right?
I think well, you sort of, I think you I'm not going to speak to this. You do have some provisions in your plans, like, so you have travel and lodging benefits already in your plans for specific services. So for example, for Providence they have a general travel and lodging benefit, then they have one for transplants. And then MODA has one for transplants. And so what we were trying to do is to just come up with one benefit that would apply to travel and lodging for pretty much any service as long as it complied in terms of what we've outlined here. So
okay. So the innovation work group has been working on a COE plan for a few, like joint knee replacement, that sort of thing, for like years, a couple of years now, and have talked about travel and whatever. And so would this effectively be making a decision sort of about that before that proposal has come here, I guess? Like, how does it fit with that work, I guess?
Yeah, so I'll step in here first. So in terms of how that fits, I think we're trying to look at it holistically, Sean. So when we've had discussions about travel for the COE, we've definitely involved Sally and Andrew and others to try to make sure, we've been looking at maybe one travel benefit for everything versus one specifically for COE. I mean, we've had those discussions. I don't think we've necessarily settled upon something, especially with some of the issues with OEB and travel benefits beyond the IRS limits and administering that. So it's all holistic. As we talk about this here, I think we're definitely keeping the COE in mind. So I don't think we've come up with a final decision, recommendation here, but it will definitely tie into the COE and IWG.
and both options would support the COE. I mean, really, that's the intent, is that would support any efforts done to toward developing a COE and any kind of travel that would be required.
Yeah, that's good. But I just, like, if we make the decision, but OEB doesn't make the same decision, then sort of the purpose of the innovation work group's been sort of like circumvented. See, so that's why I was curious.
Yeah, that's definitely a consideration. I mean, the restrictions upon the boards, that's definitely been under consideration. I don't know if it's necessarily circumvents IWG, but we would bring it up and discuss it in the context in the IWG. But Margaret, you had a comment?
Yeah, thanks, Emery. I just wanted to chime in here because I think one thing to note is, if the PEB board were to make a decision around sort of a standardized travel and lodging benefit, that would be sort of condition agnostic across the board. That doesn't preclude a future review and consideration of an enhanced travel benefit, so to speak, for something particular, such as a COE program. I sort of look at it and chime in if I'm thinking about this the wrong way, but the way I sort of look at this is that this decision would be related to travel and lodging benefits across the board for services in the PEB plan. And then a future decision related to a Centers of Excellence program might take other factors into consideration and modify aspects of benefits. That's still to be determined through the work of the innovation work group, but a benefit such as this wouldn't preclude that future work from happening.
Yeah, that's helpful. But just from my own clarity, aside from the innovation work group, do we currently have other COEs in place right now for other procedures like reproductive health services or even transplants or stuff like that? I mean, I'm just curious.
I think Providence has a minor one, some small ones. I think that there's a maternity COE. There's a couple, definitely some small ones that don't get publicized very much. I don't, yeah. So
And I think
yes,
transplants. Yeah, I think transplants too, Emery. Yeah.
For Providence only?
I want to say Kaiser probably has one too for
And
transplants.
I would suspect usually transplants go through a COE tied to the stop loss. If there is stop
Okay.
loss.
All right, and that's really kind of the main distinction between option 1 and option 2.
Mm-hmm.
Okay. All right.
Yeah, and
Thanks.
Moda just chimed in. They do have one for transplants as well.
Any other questions or comments? Since we have, I think we have just a few more minutes to get through some more slides. Okay, dental renewals. Quickly go through these. So you've seen the overall cost estimate from Emory. This is shows the increase in administrative fee of 19 cents or 2.9%. And then a couple of options we asked MODA to provide some cost impact on, and one was both are for the ortho benefit. One's increasing the lifetime maximum to 2,000 and one to 2,500. So you can see the estimated cost impact there. Should we keep moving since we have more? On Kaiser, as Emery mentioned, it's a flat renewal that calculated at a 4.8% decrease initially, which is conservative given the trend. And last year, the preliminary increase was 3.4, final was 0. And so we'll continue to, there are no changes, administrative changes or benefit changes for the dental plans, and we'll continue to work on negotiating since this is preliminary. And then for Willamette Dental Group, there's a rate hold. And the one enhancement is that they currently have a program where they provide basically a get acquainted visit for people to come in and get that first visit covered with no cost sharing. And they'd like to continue that copay waiver because it's been pretty successful. They've had over 2,000 people take advantage of it. And so they'd like to continue that into next year so that they can give members the opportunity to get acquainted and get established in the clinic with no cost share. And then vision. Talk fast. So VSP, we've reviewed the fee's not going to be changing. We reviewed what the estimated cost is in terms of claims. VSP is recommending some slight changes to the Plus plan in order to provide some greater value to members who are electing the Plus plan. And that was it's a slight increase to the contact lens allowance. So that it currently, the frame and contact lens allowance they'd like to increase it to 250 from the current of 225 in order to provide some differential between the two plans. And so there's a cost impact of about $360,000 to that. And then next, Maggie. So I'm going to go quickly. And your other programs, the spending accounts, the health FSA, the dependent care, community program, there's no change. And also with COBRA and retiree premium administration, VHS is not asking for any increase in those fees either. And then if we continue on standard, the standard plans will renew. We don't have a renewal yet, but we have started preliminary discussions with them regarding the Oregon paid family and medical leave, which goes into effect in September. And working on some analysis to determine whether, whether it makes sense to retain the short-term disability plans after September or to retain them. And so we will be reporting more on that in the next board meeting. And then I think this is my last one. So long-term care, this is an optional program offered to employees. It is a plan that hasn't had an increase in a few years. And the renewal we have not received yet because it's filed with the state. It has to be filed and approved before we can see it. So we're waiting to receive that, and we will continue to track it, and we hope to be able to report at a subsequent board meeting. I think that's it.
Right. Thank you, Sally. Look at that. It just turned to 10:40. We
I
are
know,
right on
that went
time.
really fast.
Anybody have whiplash? You know, there's
I'm sorry about
so there's a
that.
lot of content with these round ones, you know, it's like really drinking from a fire hose. So hopefully that wasn't too overwhelming. You know, when we get back with you in a month, we'll be reviewing the round 2 responses. At that time, we'll have some additional information on the carrier programs, a refreshed composite rate increase based on additional claims experience. And we'll be continuing to work with your carrier partners on proposed fees and rates between now and then as well.
Yeah, so thank you, Andrew, Sally, Emery, also Sarah for the information on the diabetes drugs. It is a ton of information. I think one of the takeaways I'm seeing is it's hard with the renewal rates to see that our managed care plans have the high increases that we're seeing compared to the statewide plan, which isn't as managed. And I think that's something that overall we need to be paying attention to as well, since, you know, we want to make sure that we have good managed care, and that's not showing up this particular renewal cycle, especially when we're seeing the increases between the highest cost plans and our more managed care plans, the gap there closing. So I just want to comment on that. I know we have a renewal up next that we are all going to need to vote on. So I want to make sure we move to that and pay attention to that. And I think, Andrew, it looks like you're on again and are going to walk us through that.
Yes, thank you, Siobhan. And I think we've got 25 minutes. I think that'll be plenty of time. Hopefully board members have had an opportunity to look through these slides, which were provided a couple of weeks ago at this point, but if not, that's okay. Sorry, well, I just get oriented here and pull up my version of the deck. Okay. And so this one does, we are asking for action from the board today. The Canopy EAP renews on 7/1, which is why we're asking for your action, a little bit of a different rhythm than your 1/1 renewals. And so we probably don't need to go through every slide in this deck, but we do have some background on the program, what the renewals have looked like historically, and there are some options that we'd like to propose and talk through with you all. And so let's see, maybe if we want to jump to slide 4 real quick, Maggie, just to sort of ground everyone in, you know, what all is included. And you know, as you all know, the EAP is really a great resource from a well-being perspective. It really offers lots of services that sort of span the spectrum of potential well-being needs. So, you know, physical and emotional, but also, you know, financial resources. And so we've outlined what some of those sample topics are, as well as services on this slide. This is an employer-paid benefit, and it is optional for the agencies to purchase or not. And today they have 2 options. Agencies do either a 3 or a 5 counseling session model. And so one of the changes that we've worked with Canopy on, and what we'd like to discuss with you, is to expand that to provide additional options for agencies, including higher visit models, as well as the addition of a peer-to-peer solution, which we think sort of provides a sort of a neat benefit that really is something that's not offered today at all. And so I guess with that, Sally, I'll hand it over to you. Thank you, Maggie. I see you've pulled up the rate changes under these two options, the first without the supportive and the second with supportive.
And Sally, this is Brian. Before you jump in, if I may just provide just a little context too for the board and some background. So earlier this year, or last year, excuse me, in 2022, the board asked us to take this renewal through PMAC and to have Canopy present some of this information to PMAC in light of the pandemic and based on what the latest and greatest is in terms of identifying member needs post-pandemic. And so we did not ask PMAC to make specific recommendations in terms of approving or not approving. Rather, they are just asking the board to consider all these options that Canopy has proposed as part of its renewal. The reason why I didn't ask them to make a specific recommendation, yay or nay, is because this will involve some additional cost to state agencies, and I didn't want to put our advisory committee in a position where they were making a specific recommendations that had fiscal impacts on other agencies. This is an optional program, so agencies are not required to participate in PEBB's EAP program, but historically we've had, I think, pretty darn close to 100% participation. So just a little bit of background.
Awesome, thank you. And this shows the two options. I should note that the renewal with Canopy's renewal is a 2-year renewal. So these fees would be for 2 years, so until 2026. And so the first, you can see the current with the counseling and the coaching, and one change is that the coaching services are going to match the counseling visits under these options. So because currently under the 5-visit model, there's only 3 coaching visits. It'll now be 5 coaching visits that are embedded. And so what they provided was these 4 options. And then under option 2, the only difference is that we've added the supportive fee to that, which is 15 cents per employee per month. Out on the street, it's 25 cents. So we got it reduced for the first year. And it'll go up next year if you decided to add supportive. But we asked for these 4 options also to provide agencies a few more options to choose from in terms of what they think would be the best model to support their employees. So Maggie, if you go to the next slide, and I don't remember what we have, but so it might be helpful. Actually, we might want to go backwards, Maggie. I'm just trying to, can we go back and show some of the utilization just because I thought that might be helpful? I don't know where this is in the, oh, there you go. I thought this might be helpful for you to see because in terms of the current model, you get 3 visits or 5 visits and how the program's been utilized. So we can't tell how many people may have needed more than 5 visits, hypothetically, or more than 3 visits, but we at least got the average number of sessions by the session model. So you can see the 3-session model in 2022, the average visits was 2.46. On the 5, it was 3.54. And then we got some stratification. So I thought it'd be interesting to see how many people only use 1 session, how many people use 3 sessions. So you can kind of see how that's broken down here to give you some sense of the utilization under the current program of those utilizing it. And so I thought that might be helpful to see just for some context. And then if we go, did we have a question? No, I didn't see a question. So if Maggie, if we can go to, so here's, I know you've seen this information on the supportive, but it's really would provide members with this anonymous, peer-to-peer small group chats with individuals who they're matched up with based on their similar needs and shared experiences. And these chats are professionally moderated. They're all, psychology students, LCSWs, or PhDs, and it's available anytime. So it provides just an additional layer of support for people when they need it, when and where they need it. And so we thought this was a great option to be adding to the program as another way of accessing care. Maggie, do you want to? Oh, go ahead.
Oh, I just wanted to make a couple comments. I know we've been working with Canopy for many years, and my understanding is they also have a really good handoff program to carriers when folks are done with the sessions through Canopy, and they happen much more quickly, that people can get in and receive support much more quickly than often through carriers, because people have to wait for mental health support often with the carriers they have. So I just wanted to name that. And I believe, and Kimberly, I want to put you on the spot. I feel like you've talked about this before in terms of the additional support this has provided in corrections. I know some of our agencies, which have workforces that, deal with a lot of trauma in their work, utilize these services. And I don't know if I've ever seen a breakdown by agency. Like Kimberly, I don't know if you wanted to comment on this program.
Well, we're kind of, Ali's probably got a little bit more conversation, but we've got a little bit of our we call it CISM now, our EAP, our ESS, our teams are having a little bit of a problem with delivery with Canopy. And so they've actually written a letter about their concerns about getting a BHS provider for DOC staff, because they've been looking into that corrections has a little bit different stressors, just like state police would, or that kind of thing. So I love all the things that Canopy, I believe, offers us and that kind of thing, but I'm a little leery now because I've been invited to a lot of meetings where they're actually a little bit upset right now. So, I had one employee say to me that, when she was very distraught, they wanted to work her through some breathing exercises and stuff, and she wanted a doctor. She didn't want to breathe. So again, I want to be careful representing DOC, because right now DOC is working with Ali and kind of bringing forward some concerns. So, because we have a director, a deputy director, assistant director, Gail Lavario, through HR, that's been doing some contacts. And but again, all the extra, everything that Canopy offers, I was kind of excited about this supportive. And then I realized it said new, and I was like, oh, so that's why my people haven't used it, because this 24/7 is definitely something we need in corrections. So anyway, sorry, I kind of danced around that a little bit.
No, thanks, Kimberly.
Yeah, I mean, thanks, Kimberly. That's definitely something that, I'd say a handful of agencies that have, especially in the last couple of years, literally crisis after crisis on a daily basis, that, would burn through their visits and even have crises that escalate beyond an EAP. So we're looking at some different options for, for agencies like the Health Authority, state police, corrections. There are certain vendors that provide, specific crisis intervention services, and it's just that I think we were talking with Brian as well, and getting PEBB member advisory committee involved in looking at options as well. I think right now it's how can we enhance our current EAP, who we have a really good partnership with, provide the best support possible, while looking, at options to provide service to that other handful of agencies that need something beyond that.
And Ali and Kimberly, I just let you know too, I have been in some discussions with I forget the person's name, but over at Corrections, about some of the general issues they've had. And from what I'm seeing too, I think there's another conversation we may want to continue having with corrections and Canopy offline about different types of services. I think there's a certain set of needs that corrections may have that is unique, that just isn't completely getting fulfilled. I'm not sure yet whether Canopy is the one to provide those specific needs. I feel like I need to get a little more information. So I feel like it would be completely appropriate with the board decision to ask for maybe some sort of specific update, in the near future about, one, can we at least identify more specifically what corrections needs are, and maybe some of the other safety officers' needs are, because I think we want to figure out what do we have the ability to fulfill through our current contract with Canopy versus, maybe there are needs that just won't fit under the, our current EAP structure that are highly specialized, if that makes sense.
Thanks, Brian. Charna, did you have something to add?
I just wanted to do a clarification on the supportive features. It was my understanding that the moderators were going to be licensed clinical social worker students, or so that the folks that would be monitoring might be a PhD or an LSW. They're going to be reviewing the work. So Sally, could you speak to that? Did I misunderstand that?
Well, I have to go back and confirm, because this is the information, what we have illustrated on the slide is the information we were provided, that they would include psychology students, LCSWs, and PhDs, but we can confirm that, Sharna.
Thank you. I think that's an important distinction.
No, you're right, it is. We'll confirm that. Okay, well, Maggie, I don't know, what do we have next on the slide to make sure we go through? So this is the health equity review. I think you've already seen this. If we, and this is the demographic information about the moderators and then about participants. The participants are asked a question at the end of the session. And so they have a 19% response rate. And based on that response rate, this is who's been participating so far in supportive, where they've rolled this out. And then if you can continue, then here are the renewal options. So as we mentioned before, we added additional options for consideration and to be offered to the agencies, just to provide them the ability to, if they feel like their employees would benefit from a higher visit count, that is available rather than limiting to the 3 and the 5, and then the pricing associated for that with and without supportive. So it really gives them the flexibility to decide what may best support the needs of their employee and member base by each agency. The one thing I'll note about supportive, we have it in a footnote, is that it's an all or nothing proposition. So it can't be elected at the agency level, and either it's elected overall or not at all. So that's why we illustrated the pricing this way, as 2 different options. So Maggie, you want to continue? I think we just have the recommendations. So we're recommending option 2 just to provide the, we feel like supportive is a low cost value added option. So to provide some support to members who have low acuity needs, and really to provide the agencies the additional options as well in terms of the counseling and coaching visits, in terms of the slate of offerings. And then I think,
I know we need to take a vote on this. I just wanted to make a comment just based on the conversation we were having, the discussion. It's clear that the ongoing behavioral health needs to be offered through the carriers, and this is a transition sometimes for folks, and certainly the high acuity needs that are being named in Department of Corrections, State Hospital. There's other agencies too that have a lot of crises that workers are faced with in their day-to-day work. And Canopy offers, I would say, like a number of really good programs for our members, and So I appreciate this being put out here, this option 2 with the 24/7 ability for somebody to reach out if the agency chooses, and then they have the range from 3 counseling to 8 counseling and coaching sessions. So just wanted to comment on that. I don't know if anyone else has any comments or someone wants to make a motion. Do I have a motion?
This is Kimberly. I'll make a motion to approve option 2 with supportive with Canopy as presented by Mercer.
Thank you, Kimberly. Do I have a second?
I'll second. Is
Thanks,
Andy?
Thanks, Andy. All right. So I am looking for my voting sheet. I don't have it in front of me, so if I miss anyone, just let me know. We've got Kimberly with the motion, Andy with the second. Chicky, how do you vote? I heard something. I'm not sure if that was you, Chicky. I'm hearing a little bit of background. Are you able to put your vote in the? Oh, now I can
Third
hear
time's
you.
a charm, maybe? Third time's a charm? Okay.
Yes.
I vote yes.
Great. Thank you. All right. Sean, how do you vote?
Approve.
Thanks, Sean. Just want to double check. Greg, did you join us? I don't think Greg joined us. I also vote to approve. I believe that's everyone that's here, and that's a quorum. All right. So we're going with option 2 with supportive. Appreciate everyone presenting on this and the comments from OHA staff. Anything else, Andrew, on this?
No, I think that'll do it.
All right. So I do believe that we are on break. And we have a break until 11:15. So I will see all of you back at 11:15. Thank you. All right, everyone, welcome back from break. I do believe we have Valerie Swires and Jessica Clegg from VSP, so I want to make sure they're here. Janessa, looks like-
yes. Hello.
Hello. Sorry about mispronouncing your name.
Oh, don't worry about it.
All right. Welcome.
Hello.
And I will turn it over to the two of you.
Wonderful. Thank you so much. I'm Market Director Valerie Swires. Thank you very much for the opportunity to come and present to all of you today. I have Janessa Clegg with me from our Provider Network Development. She is going to provide an update, an overview on our network and our strategy in areas where we might be having a little bit of a healthcare desert. So I'm going to turn it over to Janessa, and thank you all again for your time.
Yes, thank you, Valerie. Hi, everyone. I am Janessa Clegg, and I actually met with your group around this time last year. So there may be some familiar faces here. We'll go through our network strategy today. I believe I was going to share the slides, unless, Man, would you like to share them, or would you like me to screen share and I can present? What would you prefer?
You can do it, Janessa. You can do it.
Okay, all
That's
right.
fine.
I'll go ahead and
Go
take
ahead
over
and
then.
share your slides.
Okay, give me just a moment.
Can you hear me?
Yes, can you hear me okay? Is everyone able to see the full screen here?
Yes.
Yes.
Thank you.
Okay, wonderful. All right. Well, I know we're limited for time, so I'm going to go ahead and jump right in. Today, I thought what we could start with just a quick VSP network update, looking at where we're at for access this year, identifying a few areas that I have concerns about looking at access, although I'd love to get your feedback if you have any on that. And then we'll talk a lot about our VSP network strategy. And so even since the time that we met last year, there have been a lot of changes. I will say I think we've become a lot more focused and proactive, especially in that Pacific Northwest territory. So I'm excited to share some of those updates with you. And then we'll circle back again to those concerning areas and get into a little bit more detail about how we would like to approach
Okay,
those
good.
areas. And again, we're open to feedback here, but just kind of sharing where we're at, and then close out with an open forum, any questions or other items. So, any concerns with that agenda or anything else that we want to make sure that we cover today?
Sounds good.
Okay, all right. And if you do have any questions throughout the presentation, I'm going to turn my camera off and I'm sharing screen. So Valerie, maybe if you see anything in the chat, if you wouldn't mind calling it out.
I'd be happy to. Thank you.
Okay, fantastic. All right. As of today, looking at Oregon, we're maintaining 97% access throughout the state. For our PEBB members, and I have to ask, is it PEBB or PEB? How do we pronounce that?
We say PEB.
Okay, so for our PEB members, our overall access in the state is 98%. And so when we look at our members who are living in the suburban urban areas throughout Oregon, the access is 100%. So, the access is very good there. Where we're concerned, and what we'll be discussing today, are the 2% of our PEB members who are living in those rural areas with poor access. It's about 956 of them, actually, that are living in these areas that we call healthcare deserts. And those are regions where there's insufficient access to healthcare in general. So primary care providers, pharmacies, hospitals, et cetera. And so as part of our VSP's 2023 network strategy, we've put these healthcare desert areas at the forefront and have incorporated that into our strategy. So that's going to affect a lot of the areas that we have here in Oregon. Okay, and I have to ask, are we surprised at that number, at the 2%? Is that more or less than we were expecting?
So it would be helpful when you walk through the next slide, because
Mhm.
there's just some questions that I have around access. So I don't know if you
Sure.
want to just move to the next slide.
Okay. Yeah, that's just fine. So looking at our rural areas and again, our PEB members specifically, these are some of the counties that we've identified as having access issues. Baker, Harney, and Grant counties are incredibly concerning. 100% of the members living in those counties are without access. And that means when we say without access, there is not a provider within 25 miles of their home address. We also have Coos County, which we know that that's not really so much an access issue as much as it is an appointment availability issue. A lot of the practices in that area, the ratio of members to practices that are available is just not high enough. And so appointments are looking, 30 days out, which is not the experience that we want to provide for our members. Then we also have Curry County, 87% of the members there are without access. That's concerning. Last year, we talked about Umatilla and Benton counties. Those were critical access issues last year. They have fallen off our watch list this year. Access is adequate, and we're no longer finding a shortage in those areas.
So I appreciate this slide, naming where we're seeing issues and that there were, follow up in Umatilla and Benton counties so that they're no longer critical access areas. The thing that I wanted to bring up that we had some testimony around in, I believe it was November, maybe. It was in the fall, and it was out of Douglas County, I believe, and just concern around access to providers who can provide support when there are patients with special needs.
Okay.
And whether you all have additional ways to support folks who may be, I think in this particular case, I think she named that the person was on the autism spectrum, or also dealing with, I know we've had a discussion around language access, because that can happen across the state if somebody needs a provider in a language other than English. And if you could just talk a little bit around how you deal with those kinds of access questions, accessibility issues when they come up.
Sure. So inclusion is very important to us, and we want to make sure that all of our members are covered and are having that positive experience. So what I can share is that VSP is part of our network strategy. We provide and in most cases require special training for all of our practices around supporting our special needs group populations, any of our other critical populations. That diversity inclusion training is a large part of that. Language access is something that we see often, especially with our Medicaid patients. And so VSP provides language translation materials. We have language translation both within our programs that can be incorporated into the practice, as well as member materials. So our group will actually draw up the materials for the provider to have on hand at their practice, and we'll support that financially. We also, in the case of, where we're running into, maybe there's one practice that is unable to support some of our special needs members. One that I seen recently was we had a practice that did not have a wheelchair ramp. And so it wasn't accessible to any of our members that were in wheelchair, needed that access. And that's where VSP can come in and, when it makes sense in conversation with the practice, we can financially support if there's a remodel that needs to take place, if there's technology or equipment that they don't have. And we're seeing that this is something that's an ongoing issue that the practice is unable to support. Because we never want to compromise that integrity of the network. We will jump in and support when we can. And then if it, let's say the provider is unwilling to support or accommodate those members, then we'd actually probably pursue termination of the network, just because we want to maintain that integrity.
So that's helpful to know. And then do you also have an exceptions process so that if somebody was seeing a provider that then was no longer a network,
Mhm.
If that provider was, providing the needs for folks that had accessibility issues, is there a
Mhm.
process that person can continue to see a particular provider?
Typically, what we call that is we call that our member promise or a member guarantee to guarantee a positive experience with VSP. Um, Typically, what that would look like is if the member went to see a VSP provider in the area and found that they were not able to accommodate the member, then we could go down, that resolution route of getting them services where they may need it, or covering any of the out-of-pocket costs, for example, that they incurred at that practice. For the most part, though, to initially attend or go to a practice that's out of network, we would typically only authorize that if there was an actual access issue where we did not have any VSP providers in the area. I will say, if we're hearing from a single member that there's a practice that they find that is more accommodating, I would probably look at that as more of a recruitment opportunity for VSP and see, is that somewhere where we can bring that practice into network? If not, where are their challenges? Is it our fees? Is it our materials? Can we make some compromises there to bring them on?
All right, thank you. Appreciate that.
Sure. Any other questions about these areas? Okay. All right. And I've made a note on Douglas. Do we know if that's still an active issue, or was that, I think you said November of last year?
Yes, that's my understanding, that the person is, their son was seeing someone who was in network, and then that provider is no longer in network. And then they took their son to a new practice. It didn't work out, so they took them back to the old practice that's no longer in network. That's my recollection. We do have public testimony on it, so we could pull it.
Okay. That could be a great opportunity, Valerie, maybe for us to circle back and take a closer look at that. Just made a note here.
Yeah, I'll look into that, but I believe that we did assist with that. Kathleen and I will relook at that, but I believe that we got the notification and that something was put into place, but I will double check on that.
Thank you.
Thank you.
Okay. All right, great. Okay, so I'll go ahead and jump into our network strategy for 2023. Some of the changes that we're making this year are to our recruitment strategy. When we met this time last year, we outlined our recruitment plan for these areas and committed to recruiting in those areas. And we did. We really hit them heavy. We increased fees well above and beyond our typical maximums when it made sense. We incorporated retail in those areas as much as possible. We sent our boots out on the ground to see some of these practices, hosted provider dinners, really in an attempt to strengthen relationships, not just throughout the state, but in these counties specifically. And we did see some success. We're happy about the progress, and we did see some of the counties fall off that watch list. But really, I think at this point, we've exhausted recruitment in those areas. And, VSP, we don't want to spam practices that have already declined participating with us. And so what we're looking at this year is, how can we recruit beyond the local providers? And what that means is that we're going to look at our provider network throughout the state and start communicating more heavily with providers to see where we can attract them to maybe working or opening a practice in these rural areas. This is actually something that we did do in Alaska last year. It was very successful. We hosted a few webinars and also sent out some targeted communications that helped us close some of those rural gaps. And so we're looking to explore what that could look like in Oregon this year. And again, that, just some specific examples, say we have a rural practice in one of these counties that we do have, and they're telling us they're short-staffed. Okay, well, can we provide you with one of our VSP headhunters? And our headhunter will share that employment opportunity with our optometry students who are about to graduate, or maybe other ODs throughout the state that are looking for employment opportunities. So facilitating those connections, could be really promising. And I think there's really a lot that we can do to leverage our network. And so we've established what we're calling a strike team internally, is our name for it here at VSP for Oregon. And what that entails is bringing in all of our internal partners, our marketing and communications teams, our optometry association partners. We're all going to get together and we're going to work to identify any of those opportunities in Oregon. And again, that's something that we're going to be focusing on heavily throughout this next year. Any questions about the communications? Okay. All right, I'll go and move next. And so what we're also looking at this year is increasing our financial investment. So in 2022, and again, I'll refer to our meeting last year, we talked a lot about the noise around provider fees. We were hearing that, even in years prior, but I think it really hit ahead in 2022. And so we revised our fee strategy, especially in our rural areas. And we also invested, I think it was about, I don't know, somewhere around 40 million in our private practice providers throughout the country. And that's financial investment from VSP outside of, the fee schedule where we're reimbursing them for services. So we did make those investments. We've increased revenue in several places, but we're still finding that providers are struggling with revenue. We're still seeing a lot of post-pandemic closures and things like that. So we've upped our financial investment for 2023, and we're going to continue investing in these areas here. And what that could look like is VSP financially supporting an office remodel, providing them with marketing materials. Again, our hiring and recruitment services are something that have really been received well with a lot of our private practice providers. That's something that we're willing to jump in and do so that they don't have to hire someone or facilitate that hiring themselves. And then we're also investing, just want to kind of call out the investment we made in technology last year. So we did a lot of the work last year to revamp our technology, and so we're better able to support telehealth and mobile capabilities this year. And within really just the last few weeks, actually, we closed on a partnership, two partnerships. One is an Oregon university who will be doing mobile clinic visits throughout the state. That is for our Medicaid population for now, but our hope is that we'll be able to expand that to commercial. And also a pop-up optometry group. So they're open to traveling through Oregon to host on-site clinics for members. Again, there's a lot of conversation and exploration that needs to take place to figure out where those pop-up events, would make sense. But we do have that partnership in place now, and so that'll be something that we'll be looking at more closely for this year. And really, just overall, just being more purposeful about understanding what our providers need. How are we going to support the success of their practice beyond just increasing the fees on exams? We've increased there, and so now we're looking at other ways to invest in our private practice providers. Any questions there? Comments? Okay. Move forward. All right. And so circling back then to some of our critical areas and some of the solutions that we're exploring, we talked about our doctor fee strategy, expanding, increasing fees wherever possible, recruitment beyond just our local providers. Something that we can also offer is maybe improving member promise marketing. And what that could look like is just making sure that our PEBB members in these areas are well informed of their opportunity to see an out-of-network provider that is located, locally at no, additional out-of-pocket cost or anything to them. It would be from, their side of the table, it would just be an in-network experience. And then VSP would be covering that claim cost. And we'll talk a little bit more about that. But making sure that the members here have that education will be important. That's something that Valerie and Kathleen and I can help support. VSP can offer to design some of those materials for your group, and then distribute to your members. Again, I'm not on the sales side, so I'll say whatever channel that you typically would use. And sorry about that, Valerie, if you want to jump in there, because I'm not quite sure, but.
Yes, we would
Remember.
work back with the PEB and OEB team to make sure that we had the materials that would support these solutions for
Okay,
all markets. Thank you.
great, thanks. I didn't want to speak for you too much, so.
Oh, no problem.
Sorry about that.
That's okay.
So our pop-up events, I think this is where we have a lot of promise, especially in these rural areas where there's a pretty heavy member population and there's zero access. Could it make sense for us to go out there and do a pop-up event, a clinic? That's never our first solution. We would prefer to have a brick and mortar in place. But if we are still struggling throughout the year, deploying those, same thing here with our mobile clinics. We are working on a few of our telehealth solutions. There's a few retail locations throughout the state of Oregon that may have some telehealth opportunities. So we're still in discussion about, with those, but we're looking at telehealth wherever possible. The long-term OD investment is something that I'm really excited about. We deployed this in Alaska last year. And what that could look like is VSP going in to invest in brick and mortar in the area. It could be something even as simple as possibly paying for a provider that we have in another area in Oregon to go out and travel and see patients in these areas. And VSP, when we've done that previously in Alaska, what that looks like is we fund the travel, we pay for the provider to go out, and that allows the members to have increased access. We could set up events to do once a quarter or semi-annually. We'd have to explore, where that could make sense, but that is something that we'll be looking at doing in Oregon this year. And then, and this note actually should be with Coos Bay. Coos Bay is not one of our healthcare desert areas, but I continue to list it because I know it's still a critical watch area where we're hearing some noise. So Coos Bay will be included in those strategies as well. Okay. And then I'm circling back to the VSP member promise. I just always like to reiterate this when we're talking network. VSP does guarantee our member satisfaction. And so anytime a member is not satisfied or is impacted by an access issue, any of those areas would apply. VSP will authorize the member to see an out-of-network provider. It will be the same in-network benefit level for them, and VSP will absorb 100% of the claims cost for that. So we do typically see with our out-of-network claims, of course, their UNCs are going to be higher. That's not something that your group would have to absorb. That would be something that VSP absorbs as part of our guarantee. And then I also just wanted to kind of close out to talk about success measures and what we're going to do to make sure that we're all aligned and accountable moving forward. So like I mentioned earlier, we've established an Oregon Strike team. Our first meeting is actually this week, and we'll be talking about the strategies that we've outlined today and focusing on those. We'll also be conducting a quarterly assessment of those areas and updating that chart that I showed earlier with any pilot solutions or strategies that we're currently deploying. And what I was thinking, and of course, open to frequency here, but when VSP is performing those evaluations, sharing that update with Valerie and Kathleen, and then they would be able to pass that back to your group throughout the year so that you could see the progress that we're making. And again, I have that updates quarterly, but open to whatever we'd like to see.
I do think getting the regular updates is important so that we can see how it's going. I know that in particular, I hear from our members in Douglas and Coos. I've been hearing from them in Douglas and Coos and Curry County around access. And I know that not being able to get a provider within 30 days is a frustration. And it's also just been a frustration, as you know, because there were providers within the network that are no longer in the network. So people had more access. And I know that, there are a lot of folks who live there between PEB members, OEB, who also accesses VSP. And so I do think continuing to hear how it's going and to provide the support to folks who are trying to get in and they can't get in. So getting them somewhere else and being able to be reimbursed. And I know sometimes that's a hardship for folks too, because then they're paying out of pocket and have to wait to be reimbursed. And I don't know if anyone else, any other board members have comments on access issues for folks that you're working with.
I did hear, I know I heard you say, Douglas, for appointment availability. Would it make sense? It kind of sounds to me like we could maybe add Douglas to that watch list that we have. And maybe just a note there that is that an appointment availability issue that we're hearing there?
So there's a member there who brought up the accessibility issues because of her son with special needs. I had also heard from her that there were some availability issues, not consistently the way I've heard it from Coos and Curry County. So I don't know, Ali, if you've heard any. I don't have the specific examples in Douglas County that we had out of Curry and Coos.
No, I think we were kind of waiting to see if there was going to be any other members that had similar issues, and we hadn't. But I think we'll definitely want to follow up with the member in Douglas. It doesn't sound like they've heard from VSP, so we'll want to get on top of that situation.
Okay. And we do, just to share, we do conduct our own appointment availability surveys. We actually contract with a third-party group as well. We do that quarterly. So if we were ever to conduct a quarterly survey and find a consistent issue in Oregon, we would really place ourselves on a corrective action plan, and we can share that information back with you. That isn't something that exists in Oregon today, but if you're hearing anything from your members specifically, definitely continue to communicate that. And this list is open. It's a working list, so we can add to it as needed.
Yeah, that's really helpful to know. Thank you.
And Ollie, and I'm looking back at my notes, and I remember the comment that was made at the board meeting. And we went back into our system and we never received a contact from the member regarding that issue. So our customer service representatives don't have any notes and weren't able to assist with finding another provider for the member. We don't have their contact information. I don't believe I received anything additional that would allow us to reach out, but we're happy to investigate this further, initiate our member promise, and get that handled. But like I said, we just didn't have any, the member did not contact us. I believe there were a couple of comments that were made. One was someone who spoke, and then the other two, I think, were just comments that were made, but we didn't have anything in our system. So thank you so much for passing along that information after the meeting.
Yeah, we'll definitely get that to you. Thanks, Valerie.
Thank you. Any other questions or comments on VSP Network? I think we still have a few minutes here, so I'm happy to answer any other questions or items we might have.
I'm not seeing anyone else raise their hand. So appreciate all the updates and look forward to the continued updates on access, and I can send an email after the meeting, contact information.
Great. Fantastic. Well, it was nice meeting with you all again, and you'll have my contact information following the meeting, and look forward to sharing updates, working with you through the next year.
All right. Thank you both.
Thank you, everyone. Have a great afternoon.
You too. Bye-bye. All right, so I believe we've got the HEM survey and Healthy Team, Healthy You analysis next with Monique Gill, Megan Holtorf, Claire Devine, and Aisha Gilmore, I think. We've got several folks presenting. Monique, am I handing it off to you? Welcome.
Thank you. Thank you. I'm going to go ahead and share my screen. Okay, is that coming through okay on your end?
I can see it.
Okay, great. Hello, everybody. Thanks for having us here today. My name is Monique. I'm with the Providence Center for Outcomes Research and Education, and a few of my colleagues are on the call as well, Aisha, Claire, and Megan. And we worked on this evaluation of the HEM program and Healthy Team, Healthy You. So we're going to share a little bit about that with you all today. I'm going to do just a little bit of background, but I want to spend the bulk of our time sharing the findings from the claims analysis that we did for HEM and the Healthy Team, Healthy You evaluation, which covered 3 different data sources. I'll try to save some time for questions, but also please feel free to jump in with questions along the way if you have any. So for a little bit of background, since 2012, PEBB employees have been able to enroll in the health engagement model, gives a lower deductible, and members receive a monthly incentive payment for participation if they complete a certain number of required health actions. And since 2013, Healthy Team, Healthy You has been one of the ways that a member can complete one of those required health actions. Healthy Team, Healthy You itself has changed a bit over time, with the main change being moving from being more of a team-based program to a program that doesn't require that component. And then most recently, Healthy Team, Healthy You was changed to Healthy You. But our evaluation covers the time period right before this change happened. So we're not actually going to be talking about the current version, but everything up until Healthy You. So I believe that change happened in 2021. So CORE evaluated HEM a few years ago. I want to say it was probably about 5 or 6 years ago. Some of you might remember Bill Wright and some others who came and shared some findings from the initial evaluation of the HEM program. That took place around the time of the original HEM transition. And I'm mentioning it here just because to some extent it was the basis for the current evaluation that I'm going to be talking about today. The current evaluation does a little bit of an update on HEM and then adds kind of a deeper dive on a program that's within HEM, just Healthy Team, Healthy You. So just as a little bit of a reminder on what was found in that original evaluation, we found that employees were largely satisfied with HEM, but didn't report a ton of changes in their diet, physical activity, or weight. And then when looking at healthcare claims, HEM participation was associated with lower costs, primarily driven by a reduction in inpatient visits. And the most significant cost savings were among enrollees who were over 50, those with chronic conditions, and those who were more medically complex. So in the current evaluation, we had 4 overall objectives. The first one focused on HEM, so trying to understand the impact of HEM on care utilization. And then the other 3 objectives focused on Healthy Team, Healthy You. So we were looking at the impact of Healthy Team, Healthy You on care utilization, on self-reported health and health behaviors, and then a qualitative aim around understanding program experiences and challenges and facilitators. And so to accomplish all of these objectives, we used a multi-method retrospective longitudinal comparison study design with 3 different data sources. We had claims data for Providence Health Plan PEBB members, and then we had survey and interview data from Healthy Team, Healthy You users. And so it's a lot of data, and I'm going to try to talk through as much of it as I possibly can. Okay, so jumping into the HEM side of things first. For our HEM analysis, we used an analytic method that allowed us to be able to detect differences in healthcare utilization for Providence Health Plan members who were enrolled in HEM and non-HEM health plans. And we were looking at the time period between 2011 and 2020. And so to be included in our analytic sample, an individual had to have been enrolled in a Providence Health Plan the entire time frame, but they could have switched between HEM and non-HEM plans during that time. And we looked at several different types of utilization outcomes. So they're listed here with their definitions. We had inpatient care, ED use, primary care, specialty care, and outpatient mental health care utilization. So at baseline, about half of the sample had one or more physical health conditions, 13% had one or more mental health conditions, and 8% had both. Mean age was 45, and you can see in the chart at the top about, or the majority of the sample participated in HEM for the entire time period, so it's a pretty popular type of plan. Okay, so we explored the impact of HEM in 3 different ways. We looked at annual HEM enrollment status, the number of years since initial enrollment in HEM, and the total years of HEM enrollment. I'm only going to talk about 2 of them here today, but we have a full report that can be shared out, or maybe it already has been shared out, I'm not sure. And that goes through all 3, but just for the sake of time, I'm only going to focus on 2. So the first one is annual enrollment status, which we're looking at here on the screen. So in this approach, we were comparing utilization in years when a member was enrolled in a HEM plan to years in which that individual did not enroll in a HEM plan. So the results are going to tell us whether the likelihood of each type of care utilization is higher, lower, or the same as it would have been if that individual didn't participate in HEM in that year. And so what we found overall, if we look just at this first column, we found overall that HEM enrollment was associated with higher likelihood of primary, specialty, and outpatient mental health care utilization, and a lower likelihood of ED use, and no difference in inpatient care. So what we did next was we split the sample out into a few different ways, which are in the rest of these columns. So we have individuals who are high or low on medical complexity, individuals who are over or under 50, and then individuals who had any or no chronic conditions. And in the table, you can see we kind of generally see the same pattern of higher likelihood of primary, specialty, and outpatient mental health care, and lower likelihood of ED use. And then we also see that for some of the subgroups, there's an effect on inpatient care. So for example, individuals who are over 50 had a lower likelihood of inpatient care utilization, while those who were under 50 had no difference, whether they were in a HEM or a non-HEM plan. So in general, across the board, we kind of interpreted these results as suggesting that HEM has a pretty positive effect on healthcare utilization, because we're seeing more utilization of preventive primary and specialty care, and less what we're interpreting as avoidable use of the ED and avoidable hospitalizations. Okay, so I mentioned we looked at HEM impact in 3 ways. This is the second way where we're looking at total years of enrollment. So in other words, were there additive effects of HEM enrollment over time? So if someone was enrolled in a HEM plan for multiple years, do we see an added effect? Again, we're generally seeing the same pattern in terms of the direction of effects: more primary care, more specialty care visits, more outpatient mental health visits, although that was only among members under age 50. We also found fewer ED visits, particularly for medically complex members, and fewer inpatient visits for members with chronic conditions. So again, results suggesting that HEM has a positive effect. the increase in the likelihood of mental health care utilization was one that was a little bit difficult for us to interpret because it could reflect improved access to mental health care, or it could reflect a greater need, or it could be a little bit of both. And it's difficult to kind of categorize that as a positive or a negative, but it's something that we thought was interesting. Okay, I'm going to move into our Healthy Teen, Healthy You results. So first, for the claims analysis that we did with Healthy Teen, Healthy You, we used a slightly different approach than what I've been talking about. We used something called difference and differences, which meant that we were comparing utilization for Healthy Teen, Healthy You participants and non-participants before and after enrollment in the program. And so this table is showing the characteristics of the overall sample in the first column, the control group, which is non-participant, people who did not participate in Healthy Teen, Healthy You, and then our cases, which are people who did participate in Healthy Teen, Healthy You. And so what this tells us is that participants, people who chose to participate in Healthy Teen, Healthy You were slightly younger. They were more likely to be female sex, more likely to be white, more likely to reside in a rural area, and they had higher levels of medical complexity compared to non-participants. Okay, so in terms of impact on healthcare utilization, we were looking at the same 5 types of care, which is in the chart on the bottom left. But what we're seeing there is that there was no significant change in the likelihood of primary specialty, inpatient, or ED utilization. None of those relative risks were significant because our confidence intervals include 1. But if we look at outpatient mental health, we do see an impact there. So compared to non-participants, people who did participate in Healthy Teen, Healthy You were significantly less likely to have an outpatient mental health visit in the year following enrollment. So we broke that down a little bit further, looking at the chart on the right. That decreased likelihood among participants of having an outpatient mental health visit was driven entirely by an increase in the non-Healthy Teen, Healthy You control group. So what that's telling us is that participation in Healthy Teen, Healthy You might have been protective and attenuated an increase that we would have otherwise expected to see in the Healthy Teen, Healthy You group. You can see at baseline, both of those groups have similar rates of utilization. So there's pretty good evidence here that there's some level of protection that's happening against an increase that we would have expected to see. Again, just like with HEM, interpreting mental health care utilization is complicated and not super straightforward. So it's difficult to say whether higher or lower utilization is necessarily a good thing, but I think it raises the question of what is it that Healthy Teen, Healthy You is doing or providing that might be meeting the mental health needs of participants such that they're not seeking care elsewhere. So that was sort of our main takeaway with that finding. Okay, moving away from claims and getting a bit directly from participants themselves. So we did a survey of recent Healthy Teen, Healthy You users at a matched sample of employees who never participated in Healthy Teen, Healthy You. We sent that out to about 3,600 PEB employees and had a response rate of about 23%. And then that was a similar response rate across both participants and non-participants. For the health outcomes that we asked about in the survey, I think every time I share this chart on Teams, it looks a little strange, but in the version that's in your packet, the image should look clearer than this. So we asked about several different health outcomes, which are listed on this chart here. We didn't find any significant differences between Healthy Teen, Healthy You users and non-users on any of these behaviors. The only outcome that was marginally significant was physical health. So the Healthy Teen, Healthy You group was slightly less likely to report good physical health compared to the non-Healthy Teen, Healthy You group. So because of that finding, and then also when I talked about kind of baseline characteristics of users and non-users, we saw that users were more likely to be medically complex. So we thought that those things together are kind of telling us that PEB employees with specific health challenges might have an increased interest in a program like Healthy Team Healthy You, with it being slightly more involved. Perhaps people with specific goals or specific health needs are seeking out a program like Healthy Team Healthy You. These are a few other survey findings. I'm going to go forward just for the sake of time, but they're in here in case you want to revisit those, because I want to talk about program satisfaction a little bit. So on the survey, we asked Healthy Team Healthy users about their satisfaction with the program, and overall it was pretty high. The most common barriers that employees reported were lack of time and lack of support from their employers for participating in Healthy Team Healthy You. And what we're showing on the chart on the right is that overall satisfaction was lowest for folks who reported the highest number of barriers and vice versa. So barriers to using the program were pretty closely tied to program satisfaction. And finally, we asked about wanting whether participants wanted program elements that were more relevant to their culture, identity, or language. And we found that Black, Indigenous, and people of color who responded to the survey were more likely to agree with that statement than white respondents. Okay, the last thing I'll share are a very quick overview of our interview findings. We interviewed 20 current and former Healthy Team Healthy You participants to learn more about their experience with the program. And we had 4 main takeaways, which are shown on the screen. I'm going to touch on just 2 of them. The first one, personalization. So participants wanted to see more programming that was tailored to their specific goals and needs. This is interesting because of that same thing I mentioned a few minutes ago about the claims in the survey findings suggesting that more medically complex members tend to choose or seek out Healthy Team Healthy You. And so that desire for personalization kind of connected all of those dots for us. Personalization also included things like thinking about accessibility, for example, making sure that the videos in the program had closed captioning. The other theme that I'll touch on is clarity and communication. So there was some confusion among members about how Healthy Team Healthy You had changed over time, and there was quite a bit of difficulty distinguishing it from other PEB programs. And so even though branding of Healthy Team Healthy You or branding of different wellness programs may not be kind of highest priority for PEB, that lack of clarity might create some barriers for participants who are trying to access information or resources that they've seen before and they want to revisit. It's hard to kind of remember what they were accessing and where to go back to find that information, especially in a time when we're all surrounded by so much health information and messaging. Okay, so just to wrap up, a few takeaways across all the different analyses that we did. One thing that we wanted to point out is that the incentive to participate in Healthy Team Healthy You is much lower compared to HEM in general, because there's a clear financial benefit for HEM. And so those who are choosing Healthy Team Healthy You to fulfill their health actions are likely going to be systematically different from those who don't. And we saw a little bit of that in the way we described the sample. And so those differences highlight the importance of thinking about whose program experiences are not represented in this evaluation and how those perspectives could be included in future evaluations. The second takeaway has to do with meeting employee needs. There were quite a few subgroup differences in utilization, and there's self-selection into programs like Healthy Team Healthy You. And then participants also talked about wanting more targeted and personalized programming. And so all of that, I think, together underscores an opportunity for PEB to think about those factors in designing programming and offering options to employees. Third thing, supporting mental health came up as an important takeaway, mainly because we had a lot of questions about whether and how needs are being met, especially in a time when burnout and mental health are growing areas of concern for many employers. And so it kind of just served as a reminder that mental health should be considered an important component of supporting employee wellness overall. And then last, we heard from participants that they're really looking for programming that's accessible to all types of users. They would love to see options that don't require additional screen time because of all the time that we are all now spending at our computers, especially since the pandemic began. So those are our 4 big takeaways, I think. And I think the last thing I just have is a thank you to all the study participants, also Margaret. And I know Margaret has brought in various people from the PEB team to support along the way, whose names aren't listed here, but thank you to all of them, PHP team, and then our team at CORE as well. So I think I probably used up all the time, so I'm sorry about that, but if anyone has quick questions, I'm happy to take them.
Right, I don't think I'm seeing any questions. Well, thank you, Monique. Appreciate the analysis of Healthy Team, Healthy You and the HEM program. And I think at this point, we are moving on to our communications update. And I have Erin Ward, who is providing the update, I believe.
Yep.
Erin, there
Thanks,
you
Siobhan.
are.
Yep, I'm here. Thank you. I will start sharing my, there it is. Perfect. Thank you. So hi, everyone. I am Erin Ward, and I am a principal at Mercer. And I have been partnering with PEB staff and the board on communication efforts for the last 3 years. Wanted to give you an update of what's happened over the last 3 years, since it was the board that had originally reached out about putting together a communication strategy and then working together to implement the pieces of that strategy. So I'll jump into it unless, Cindy, you have anything you want to add before I do.
Nope, go ahead.
All right, fantastic. All right, super, thanks. So wanted to just cover where we started, what we've accomplished, and what's ahead. So for those who are new to the board, just wanted to give you some background on the communication strategy process. We went through 3 different phases. We explored by interviewing various representatives from around the state. We evaluated the existing communication materials. We looked at the current website, at the existing channels that were used. We evaluated the vendor materials. And then we also looked at things like survey information that we had available to us, benchmarking what's worked at, what we've done with other public entities and what's worked. So we went through that process to come up with the strategy. And then on the next slide, you can see ultimately these were the main recommendations that we had around communication. So to work on some branding, to create an email, that turned into a monthly newsletter, but that in an email in a format that members can easily identify. Start talking about total benefits and talking about, everything that PEB provides, not just, medical, dental, and vision coverage. Really evaluating the digital tools. So taking a look at the PEB website and making recommendations for organization, enhancing content, adding content, and then also exploring other things like if mobile tools would be a good use. And then also last 2 things were providing support. So providing updates to agencies and benefit managers around the state, and also exploring how to better support member services, and then also focusing on new hires. We found that there was a need to improve the communications that were provided to new hires, in terms of adding information to the website. Also, partnering with Uplift Oregon where we could to make sure that we're advertising those sessions that have come that have been introduced and have been implemented in the last couple of years. So this was kind of an overview of the recommendations. We did go in the strategy into detail, but I won't go into that today for time. So on the next slide, you can see we did recommend that communications happen in a phase. This was a suggested timeline. Things have certainly moved around over the last 3 years, and some things we haven't actually gotten to yet. But we did think about, it was a lot of different things that we were looking to implement, and so we were looking to do it over time in a way that would work for PEB, and so we weren't overwhelming everybody because PEB staff time is tight, and we wanted to make sure that we were focusing on the high value items or low hanging fruit as well early on, and then move into different things at a later time. So on the next slide, this is really a recap of how far we've come and what's ahead. So I know this is a lot of things, but in truth, we have done a lot of work over the last 3 years. So the first row along the top is a summary of what has been accomplished. And I do have some slides on the back that show some examples of what we've done. But on the branding side, we did come up with a PEB specific look and feel that has been used for the newsletters. We're also using those colors in like the open enrollment materials that have come out. We have come up with an email template. It does keep evolving as we get feedback and as we're trying to, improve the emails that are coming out. But we're doing monthly benefit newsletters with vendor partner articles. We're also providing a monthly webinar calendar to advertise the different webinars that the vendors are providing. And we have also moved to a Mercer platform for distribution since there were some limitations with the Gov delivery system. And so, and kind of to help support the PEB staff and take some of that work off their plates. We have also been talking about total benefits. We've been highlighting monthly Did You Know spotlights. We have been including regular articles about the board and what the board does and how the board supports members. We've created a new hire video, and we are also working on a wellness resource guide. So that's in progress and it should be ready hopefully soon. On the digital side, we conducted focus groups to look at the PEB website and get feedback directly from members about what they liked about the site, what they'd like to see on the site, what could be improved. And from that, we have taken that information to come up with recommendations about an overall site organization and what that could look like, as well as how we could change the homepage, add colors, add photos, use bigger fonts, all the different feedback that we heard from members. And then we're taking a look at the other pages as well. So we are looking at the new hire page. We're also moving into the well-being next. And then also from that, there was a lot of feedback about a live chat or a chat bot. So we have been investigating those options and if that would be a good add for the PEB site so that members can easily access member services. On the support side, we've done a member services survey and we've helped with analyzing those comments. We've also helped with the open enrollment sneak peek. And then we have also taken the guides and put them into a digital version, and those are now hosted online for easy access for members. For new hires, we have created a resource page on the website. So I should say we have a concept. We're in the works of getting that built, time and resources depending. But that is something that is that we have built up. We also have again that new hire video. And then in the other, we have the virtual benefits fair, which is actually a really big accomplishment that launched 2 years ago for open enrollment, and it continues to be available throughout the year for new hires and for anyone else who might need to access information about all of PEB's benefits. And then we've also been supporting the Worksite Wellness Council with ongoing wellness efforts. So that's really a summary of what we've accomplished along the top. And I know that was a lot, and I'm talking fast because I know time is limited. But what we have at the bottom there is really what's ahead, and we can look at that in more detail. I have that slide again, but you can just see that the amount of work and things that have happened over the last 2 years has been tremendous. And I think we've made a lot of progress in terms of improving education for members, improving the resources for members, and we have a lot of work that we're looking forward to doing coming soon. So Cindy, anything to add before I just go through some of the samples?
No, you have covered it really well. I just want to say, while I have an opportunity, that this staff has been exceptional, and we cannot thank them enough for all the support they've provided us on communication. So I'll let you continue.
And you're great partners too, so just throw that in. So on the next page, just wanted to highlight, just show you some of the things. So this is in terms of the branding, just wanted to show you some samples so you can see how the look and feel is the same. You can see there's some screenshots of the webinar emails that we do, the webinar calendar, the newsletters there on the right-hand side, and then also a screenshot of the new homepage concept that we're working towards, but you can see how everything ties together in terms of look and feel. We have a nice color palette that we're using and building. So each month we try to bring in colors from that color palette and make everything consistent. On the next slide. Thank you. Just back to the email. So this is a different month of emails, but again, you can see the webinar calendar there at the bottom. You can see the newsletter off to the side and then the email. And just so you know, with the newsletter, the email that comes out is like bite-sized information. And if you want to click in, you can then click, and on the PEB website, there is more information in the newsletter. So a PDF that you can access to get more details about each one of those articles that's listed there. On the next slide, you can see samples of kind of the total benefit things that we've done. So we've been including information about the board. That's that in the top right corner, that's a sample of one of those articles. There's a screenshot of the video that we've done, one of the Did You Know spotlights. And then the sample here is, it's from the OWeb Wellness Guide, but we are creating, like I said, something similar for PEB. And so that's kind of the vision of what we're moving for, is for a digital guide that really summarizes all the different wellness tools that are available to members. On the next slide, here's digital. So this is really in process here, but again, there's a screenshot of the homepage concept that we're working towards. You can see a screenshot of the site map and how we're hoping to reorganize the site to make information easier to find with less clicks. And then the third shot there is just a picture from the reports from when we did the focus groups and the information that we gleaned from members directly. On the next slide. Thank you. So this is support. So this is some of the open enrollment communications, as well as the analyzing and coding of the member services write-in comments. So you can see what's showing here is it was the open enrollment guide, and then also we helped with the sneak peek, which is the email that goes out to people that says, hey, here's all the things that's happening for the next year. And then the survey, that's the report that shows all the how all the different comments and the different topics and themes that people identified. And then on the next slide, for the new hires, we have the picture of the new hire video there. Again, that's just a screenshot, but anybody could access that up on the PEB website. And on the right-hand side, this is a concept for the new hire page that's going to be built onto the PEB site. There are some new hire resources there now, but we're hoping to reorganize and revamp that page to the concept that you're seeing here on the right-hand side. All right, I think yes, one last thing. And so this is really just the virtual benefits fair along the bottom. This is a great resource. If you haven't been to see it, please go check it out. You can link to it from the PEB website. But you can see the first screenshot is the lobby you come into, and then from there you can go into a well-being room. You can go into a new hire resource room. You can go see different booths for each of the vendor partners. On the right-hand side, it shows what one of those booths are and what you might see there. And then at the top there, that's just one of the screenshots of the things that we've been doing to support the Worksite Wellness Council. All right, and then last but not least, I believe, yes. So this is what we're looking at. So what's ahead? So this is the same as what we had looked on that other summary slide, but just wanted to make it bigger and easier to see. But we have a lot of things ahead that we're planning to do. We're going to keep up with the monthly newsletters. We're going to keep up with the monthly webinar calendars. We're keeping up with the virtual benefit fairs, but we are hoping to add in additional things. We're going to keep working on the website and looking on different pages and creating different concepts to, revamp the site and really take that member feedback that we received to continue, or so that site continues to be a great resource, because everybody loves the site. They just felt like, oh, sometimes things are hard to find, or maybe we need some more color. So just trying to make it a resource that's really valued. Let's see. There's a lot of things. I won't cover everything, but we've done a lot of work and really proud to be partnering with PEB on everything. So please let me know if you have any questions or anything you want to make sure that we take back and that we continue to focus on as we move forward.
Really appreciate all the work, and thank you for taking us through this and for being patient around doing your presentation. I know you were prepared at previous board meetings to give us the communications update. Board members, any questions? All right. It's nice to see all this work, and yes, this is progress on PEB's long-term goal. So
great. Well, thank you for letting us share a summary of what we've done. We appreciate it.
Yeah. And I believe we've got Margaret, you up next with an innovations work group update.
Yeah, hi. Thanks for having me. So just a few tidbits to share with the board related to the innovation work group status and what the subcommittee's been working on. Currently, this year, looking at 2023, the IW has a couple of major things on its plate. Really, the biggest one being continuation of development of a Centers of Excellence program for musculoskeletal conditions, specifically for knee and hip replacement surgeries. And so looking ahead, the work group will be meeting later this afternoon. The main thing on the agenda for this afternoon, one of the main topics is really review of the 2023 project plan and timeframe for next steps on the COE work. One major body of work that is currently underway is to obtain an additional year of data related to service utilization and outcomes, that being data from the 2021 calendar year, so that as we're looking at tiering facilities and identifying the highest quality providers for the Centers of Excellence program, we're doing that with the most up-to-date data as possible. So we're working with APAC to obtain additional data so that we can be able to help that inform ultimate recommendations. In terms of the project plan for this year, one thing we do expect is that we will be coming to the board, both boards, both OEB and PEB, in late spring after renewals are wrapped up, with a more comprehensive status update and sort of regrounding in the whole framework for the Centers of Excellence program, as well as highlighting, some of the alternatives or options within the program that we're looking at. Part of our goal in having that sort of regrounding and comprehensive update in the late spring is so that we can get feedback and input from the boards, including identification of any sort of points of interest or concern, so that we can spend some additional time in those areas, because we expect that we'll be coming back to the boards in the fall of 23, with options and recommendations for the boards to consider and hopefully adopt for the following plan year, which would be the plan year that starts October of 24 for OEB and January of 25 for PEB. So as you've noticed this year, as part of the renewals, we are not looking at any plan design changes or renewal options related to the Centers of Excellence project, but we do anticipate that those will be part of the renewals for next year. So a lot of this innovations work group, 2023 work is really going to be focusing on continuing to build out and develop that Centers of Excellence option. Additionally, on this afternoon's meeting agenda, the work group is going to be taking an initial look at a couple of the performance guarantees that we have incorporated into PEB's contract, specifically the financial trend guarantee, which is already in contract and has been for a couple of years now. We are also looking at incorporating an additional guarantee related to the value-based payment targets established in Oregon's VBP compact. So the work group will be this afternoon reviewing and discussing some initial, during round one renewals, we always offer the option for carriers to share any input or suggestions or proposals related to any of the performance guarantees. So we will be taking a look at some of the initial response that we received from carriers related to those guarantees and having some work group discussion around the guarantees in general. So those are the two main things the work group is taking a look at this afternoon. As I mentioned, Centers of Excellence is going to be going ongoing throughout the year. The performance guarantees, we will absolutely be working to wrap any discussion around those in line with completion of renewals. So in the April-May timeframe, those guarantees need to be settled before the renewals are finalized. And then one other additional body of work that's currently in review, the work group took a look at their January meeting and has some additional follow-up in process over the next month or two, is related to level of payments for both OEB and PEB. And specifically, this is data that looked at the payment levels for PEB and OEB services across different healthcare service categories and benchmarked those to Medicare rates for services. So looking like as a percent of Medicare, what are PEB and OEB payments for different, across the board, different categories of services. So there was some good work group discussion there in January, some follow-up analyses and additional information that was identified that was requested. And so that's in process and will continue into March for further discussion. I think some of the hope of that work is really to identify where are we seeing areas where perhaps the level of payment when we look at what Medicare rates are is maybe significantly different from what we would consider to be reasonable or appropriate, and potentially identify some opportunity to look at where there might be some opportunities to work around payment rates. So I'm happy to take any questions about any of that. It's a lot of work in process and a lot of detailed work. So we are always grateful to be able to bring updates to the board and seek any feedback or thoughts you want to share.
Thank you for the update, Margaret, and also just want to appreciate all of your work and the Innovations Work Group, as well as Kimberly and Sean too. I know that makes for a very long Tuesdays.
It does. And one final thing I will note, and I have kind of reached out to the board, is that we are interested in seeking an additional PEB member who might be available to join Kimberly and Sean and represent PEB on the work group. Currently, OEB has 3 members participating in the work group, and we have 2 from PEB, and we're just, in the interest of kind of building that capacity, are seeking another board member. So I know this is a really busy time of year to be posing that question, but just mention it again so that, folks can perhaps take that under consideration.
Right. Thanks, Margaret. And
Thank you.
Yeah, and I believe we now have Ali with an action item for us, I think. Go ahead, Ali.
Yeah, thanks, Siobhan. Probably not an action item today, but certainly leave that option open. And if anybody is interested in participating on the IWG, feel free to reach out to me and or Margaret, and we'd be happy to talk more with you about it. So board meeting options, and see if Rose can get this handout up. I'll just start jumping in here. So after the following, the 2 in-person retreats, there were some questions about exploring the format to the board meetings. See anything yet? It's okay, Rose, I can talk through it.
It shows that it's up to me. It's not up really. I'll try again.
Okay. No worries. I'll just keep talking. Staff came up with several options for the board to consider for monthly board meetings going forward. I can tell the board that there's no other Oregon Health Authority boards or commissions that have committed to in-person meetings. So, and that's including the Oregon Health Policy Board themselves. So they're still all monthly virtual meetings. So there is no external pressure to meet in one format or the other. If the board would like to consider the following options I'll talk about, then staff can follow up with a survey to determine if there's a majority opinion. We'd like to get to a consensus, obviously, so that we can bring the results back to the March board meeting. But the meeting options that we've come up with, and we can execute on all 4 of these, are to go back to essentially the way it used to be in-person meetings, where the expectation is that all board members attend the meetings in person. There'd obviously be a phone-in, login, but the expectation is it would be in person. The second option would be hybrid meetings, and where those who prefer to be in person may do so, while others may attend virtually. The software continues to change with hybrid meetings. It's still not exactly where we want it, but we can deliver on that. The third is continue the current practice of meeting virtually. And actually, I'd say number 4 is really the current practice. That's intermittent in-person meetings. So similar to the in-person retreats, we would have meetings held either 100% virtual or 100% in person. We'd continue to hold the majority of meetings virtually and schedule 1, 2, or more than that in-person meetings annually. So again, jumping to the action items, and I'll entertain any questions, but proceed with one of the options listed above. The board obviously can elect to revisit the decision as often as they want, or 2, proceed with the survey to capture further input from board members, especially we're missing a few today, on the options listed above, and report back on survey results at the March board meeting. Any questions, comments? Andrea?
So I just wanted to say, what's funny is I don't have the medical background, but I have a communication background. That as convenient as hybrid meetings are, they are not as effective when you have some online and some not. So just a heads up that is actually something that can be very difficult. I mean, sometimes if necessary, but so far research has said that it's not as efficient or effective as either in person or all virtual. And they recommend that if you're going to have anybody doing it virtually, all people should be doing it virtually.
Thank you. Yeah, the format we don't want is, you know, to have people in a room and then have it just be one little box and voices kind of come out of the little box, so you're never really quite sure who's talking. And we're looking at some options. The legislature actually has a pretty good system that kind of zeroes in on the speaker, and so we're exploring that and some other options. Kimberly.
So we all know I love being in person. So we're just going record, just because I feel like that's how we actually network and bond. But I think that what has worked is that option 4, when we have a retreat, that then we do all get together and really address the needs that we need in person. But, you know, I think virtual meetings is probably the way that the world is going. And so I would support that. And with people missing, maybe it is best to do a Survey Monkey to get everybody's response.
Thanks, Kimberly. Chicky?
So same with Kimberly. I think number 4 works the best for me personally. I will recommend though that it also that what we determine in-person meetings based on topic and then also on weather. If we can make sure that we can take that into consideration, so that we can also make sure that folks travel safely, because I'm sure folks come from very far. And then also vote for a survey, as we have many folks out of this meeting.
Thank you.
And I'm in line with both, well, I think with everyone here around a survey of everyone, and I do appreciate the opportunities to be in person intermittently. And as you were saying, Andy, I like the level playing field if we're all in person or all virtual. So just want to say that as well.
Thank you for the feedback. We'll follow up with the survey then. Appreciate it.
All right. Thank you, Ollie. Anything else, Ollie?
No. Nope.
Oh. All right. So I believe we are at public comment. Do we have any public comment, Rose?
Oh, no public comment.
All right. Then we are going to adjourn at 12:34. Thanks, everyone.
Thank you.